delighted to welcome you to the Nuffield Trust Summit. And you're pioneering a whole new approach to the care of frail elderly people. Tell me a bit about what you've been doing in Toronto.
I think a lot of the ideas that we're working together as a team to deliver in Toronto are in response to the same challenges that we're seeing not only in Canada, across Canada, but also in the US and in the UK. I think a lot of people have done some great work across the UK, across the US and Canada, looking at individual models or individual things that they can do to achieve better care. And I think the opportunity that we've had at Mount Sinai and UHN has been really about taking a lot of those innovations, those individual innovations that we've seen elsewhere. So not reinventing the wheel, but I think what's been unique is by putting them together in terms of creating an integrated system across the care continuum that really is focused on delivering better patient and system outcomes.
And from the patient's perspective and their family's perspective, what's different about the care that you offer?
I think the first thing was we're in the same fiscal crisis that everyone else is. Our government has a growing deficit, we have a universal system of healthcare, and we don't have any more money to expand our budgets endlessly. So we really were looking at no new resources. So within existing resources, we had to think about how we could deliver better care in a more efficient manner. And our goal was really thinking about what do the patients want, what do they need. We've done really innovative external partnerships with community care agencies, with primary care physicians delivering home-based primary care, but with other groups as well to try and say, how can we actually start ensuring that our patients are getting the care they need in the community? But if they do come to the hospital, then what can we do at the level of the emergency department? How can we ensure that if a patient requires admission, we give them the best quality and the safest care possible? We're getting more patients home than we ever did before. We're now leading our region in doing that. We have less patients are actually being institutionalized, having to go to nursing home or long-term care. And when we look at our house calls programs, we know that the majority of people want to die in their own home, but in reality, 20 to 30% of Canadians can expect to do so. In our program, 70% of our patients are dying at home.
Now, you've also come up with the idea or the term an elder-friendly hospital.
Absolutely.
Tell me what you mean by that.
Absolutely. I think the elder-friendly hospital concept, or the idea that we're helping to pioneer an approach, really looks at that concept of saying, when 14% of our population in Canada, it's a little bit greater in Britain, is 65 and older, yet they represent 60% of the acute care spending dollars in our country. They represent the greatest users of our healthcare dollars in general, across both sides of the Atlantic. Our view is if every hospital, every organization should be thinking their core strategic priority should be about providing excellent elder care, because in this fiscal environment, even small improvements within working with that population can lead to large savings. So our view is not just about cost, but it's about a philosophy. It's saying the 4 key elements. What is the culture of our organization? When we're dealing with so many older patients and their families, do we value them as human beings? Do we value them as individuals? Do we recognize the importance of recognizing their unique needs and meeting them? Are we putting the right policies and procedures in place to make sure that we have policies that are supporting the needs of older adults and their families? What are the care systems and processes? So we've launched about 8 new models of care that we've integrated within our continuum at Mount Sinai over the past year. All of those things are being linked in together to make sure that we provide good, seamless care across those transition points. And finally, it even comes down to the buildings that we're in. So making sure that whenever we design a building, a facility, or even the equipment that we choose, it's equipment that can promote function and it can promote healthy aging as well.
So what would an elder-friendly hospital ward look like compared to what we have now?
Sometimes people say, well, I don't have a massive budget to reconstruct my buildings. So what are the simple things we can do? So for example, we launched an acute care for elders unit at our hospital. This is a 28-bed ward, and what we did was we're going to be moving into a brand new space within a few years, but we said, what could we do with a few $1,000s? So it meant a brighter paint color on the walls, something that we know that color on the walls can actually improve healing. We got larger clocks because we know older people have more visual impairments. We made sure the phones beside the bedside are actually large buttons. We made sure that we know that older people who have more what we call proximal muscle weakness, so weakness in their legs, that means they can't rise as easily out of a chair as a younger person. They need a little bit more of a lift. So we made sure that every toilet seat on our ward is raised a little bit higher higher. And finally, I mean, there are a number of other things, but perhaps the biggest thing was we said that we know bed rest can actually kill an older person. Every day you're in bed, you lose 5% of your function. So we said that we want the new standard of care at our hospital to be that every patient is up in their chair at least 3 times a day for their meals. We don't want to be serving them their meals in bed because that will only promote weakness.
How will you know when you've succeeded? Is this simply about trying to keep people out of hospital?
Nobody wants to be in hospital. I think that's the first aspect. So I think we always want to try and deliver the right care at the right place and at the right time. So whenever we can provide care outside of a hospital, I think that's ideal. But we know that there are certain periods of time when hospitals are important places where there's concentrated levels of expertise where we can provide care more efficiently. So I think the goal that we want to try and do is say, what are the right indicators? What are the right things that we need to be doing? And how do we monitor that? How do we monitor that in a thoughtful manner? So we make sure that it's not just about getting patients out quicker and sicker, but it's about making sure that when patients leave our hospital, they're not coming back into the hospital because we didn't manage their transition well. We want to make sure that we're monitoring our patient satisfaction. We want to make sure that we're monitoring how our staff are doing in terms of their abilities to care for older adults. We're looking at the percent of patients we're able to return back to their own home because that's where every patient I talk to wants to go. And then we're also looking at patient and staff satisfaction. I can tell you all of those individual indicators, we've seen substantial improvements in the last year by developing a synergistic model that really actually starts bringing those models together and delivering the care that our patients want.
Dr. Sinha, thank you very much.
Thank you.